Yes, good evening to all. I welcome you all for the TNFOG Bodhana PG class. This is our 12th class. Every month, last Saturday, we are conducting this PG class with presenter from one medical college and two internal from the same college and external teachers from the other college. For this program, we have the coordinator, Dr. Kalpana. So I welcome Dr. Jayanti, Dr. Subha, Dr. Sindhil Priya, Dr. Shanta Sampath for that PG program. Dr. Kalpana, you can proceed. Dr. Kalpana is the gynecologist and infertility consultant at Guru Hospital, Madurai, and she is the secretary of MOX, founder secretary of MCOT, and course director for postdoctoral fellowship in endogynecology and academic profile. She has given many guest lectures, interested in laparoscopic workshops, and had many awards for her credits from Hmb Medical University and European Continental University and from Governor of Tamil Nadu and the Madurai District Collector. Thank you. Dr. Kalpana, welcome. Kalpana, irkiya? Sari Kalpana illana CV podunga nane pottren. Sahiti
ma'am, irukanga ma'am. Mute la irukanga.
Okay.
Yes.
Thank you so much.
The teachers and the PGs.
Yeah. Thank you so much for your kind words, madam. It's my pleasure to welcome all our externals and internals. This Bodhana program has been initiated by our dynamic secretary of TNFOG, Sampath Kumari madam, and President Anjalakshi ma'am. Anjalakshi ma'am couldn't join today. This PG program will be really useful for the PGs because they learn from learned experts and their examiners, which would be really helpful for their exams. Today's topic is heavy menstrual bleeding and DUB. It's my pleasure to welcome the learned experts, internal examiners, Dr. Subha ma'am, who is a professor HOD in Salem with 25 years of experience and 21 years of UG and PG training experience. She has been a master trainer in emergency obstetric care. FOGSI published 20 articles in national and international journals, received Best Doctor Award, Best Performance Award, organized many CMEs. Welcome, ma'am.
Thank you, Kalpana, for the kind words.
Our next internal is Sindhil Priya, ma'am, who has done post-graduation in JIPMER and currently working as Deputy Medical Superintendent and Professor, Vinayaka Mission Hospital, Salem. Madam is a consultant in Akshaya Fertility Center too, EC member of Salem Muji Society. She has been trained in laparoscopy and Hafiz Rahman sir. Welcome, ma'am. Thank you, ma'am. Our next examiner is from our own society, Shanta ma'am, our dynamic vice president of Madurai Obs-Gyn Society, former professor, Department of OG, Madurai Medical College. She has been a teacher for almost 18 years, organized many live workshops in Tini, presented many papers as a faculty in national and international conferences, received Best Paper Award in Dakshin 2011 Kanyakumari. Madam's special interest is infertility, endoscopic ultrasound, and high-risk pregnancy. Welcome, ma'am. Our next examiner is Jayanti madam, who is Professor HOD, Hmb Bangalore. Welcome, ma'am.
Ma'am, Sahita, not this one, Sahita. You stop it, I will share it if you don't mind.
Okay.
For Jayanti, ma'am, 2 minutes, ma'am.
No, it's okay. It doesn't matter.
No, ma'am, 1 second, ma'am.
1 minute. Dr. Jayanti madam was past president of Bangalore OG Society, and she has conducted PG programs in Bangalore Society, and she was an organizing member in AICOG Bangalore in 2015, and she has also got many awards from FOGSI, and of all this, she is a good teacher. Everything I have done, ex-senate of RGUHS. That is from her university, I think.
Yes,
Rajiv Gandhi University of
University. Yeah.
Publications in journals and speaker at national and international conferences. Welcome, Dr. Jayanti.
Thank you, ma'am. Thank you.
Welcome, ma'am.
Kalpana PG.
Yes, yes. The next slide, please. Our presenter here is Dr. Sheila, who is a third year PG, Government Mohan Kumaramangalam Medical College. Welcome, Dr. Sheila.
Good evening, ma'am. Good evening to all.
Co-presenter, any co-presenter, only one presenter.
Only one PG is there, is it?
Yeah.
One
Felicia is a co-presenter, first year PG, Vinayaka Mission Medical College, Salem. Welcome, Felicia. Over to you, doctors, for your presentation.
Good evening, ma'am. Thank you, TNFOG and its members for giving me this opportunity. My topic for case for presentation is abnormal uterine bleeding. Mrs. X, 44-year-old female, who's a perimenopausal woman, parity 1, living 1, fully by occupation, belonging to socioeconomic class 4, according to the modified Kupasamy scale, resides at Valapadi. Her LMP is 10th May 2022. She came with chief complaints of heavy menstrual bleeding for the past 1 year, complaints of pain during menstruation for the past 6 months. History of preceding illness: she was apparently normal 1 year ago, after which she started having heavy menstrual bleedings. Her cycles were once in 60 to 70 days with a duration of 16 to 20 days of flow. She changes 5 to 6 clots per day. History of passage of clots was seen. Associated with pain during menstruation, which started on the day 1 of menstruation and continued for about 2 to 3 days during her menses. The pain was radiating to the lower back and thighs, which was spasmodic in nature. Pain got relieved with native medications. No history of excessive white discharge or weight loss or loss of appetite. History of intermenstrual bleeding was present for the past 3 months. History of easy fatigability was there for the past 6 months. No history of palpitations, orthopnea, breathlessness, or giddiness. No history of fever, abdominal distension, or nausea, vomiting. There was history of urinary complaints like increased frequency, urgency, incompetence to void for the past 3 months. No history of any burning micturition. No history of weight gain or hoarseness of voice or intolerance to heat or cold or constipation or hair loss. No history of any bleeding manifestations anywhere else in the body. No history of any other drug intake. Menstrual history. Attained menarche.
Can you go back to the first slide? Can we disturb here, man? No problem. Yeah, you can just go back to the first slide, like first presenting complaints. Yeah. So next slide, please. Yeah, here. So second slide, previous to this.
Previous slide.
Previous to this. Yeah. So passage of clots. Okay, so she was having pain during menstruation, dysmenorrhea, right?
Yes, ma'am.
Yeah, what type of dysmenorrhea you think she was having?
She's having spasmodic dysmenorrhea, ma'am.
So can you define like what is spasmodic dysmenorrhea?
It's like the colicky pain in the lower abdomen which radiates to the back. It usually starts either prior to menstruation or on the day of menstruation and will be present for 2 to 3 days. Once the normal flow happens, the dysmenorrhea will disappear.
Okay, so what are the causes you think for spasmodic dysmenorrhea?
Fibroids can cause.
Okay.
Even if the patient doesn't have fibroid, teenagers will have spasmodic dysmenorrhea.
Okay, now your patient, like you think just for your patient, what may be the causes?
She's a perimenopausal lady with irregular bleeding and heavy menstrual flow.
Yeah.
So probably she might have an underlying fibroid.
Okay. So which type of fibroid do you think she has?
Intramural fibroids can cause spasmodic dysmenorrhea. When the uterus contracts, it can cause pain.
More common in which type of fibroids?
Intramural fibroids.
Congestive dysmenorrhea is seen in which type of fibroids? So congestive is more common in intramural.
Intramural.
Submucous, they are more of spasmodic.
Spasmodic.
Yeah. Okay. Next slide. Next slide. Okay. Why did you ask for white discharge?
If she's having any other associated infections in the lower genital tract.
Okay. No, in pertaining to your her complaints, she has spasmodic dysmenorrhea and she has excessive bleeding. With that, if she has excessive white discharge, what do you think it is?
Infectious causes, ma'am.
Yeah, what infection?
Chlamydial infection.
Straight away, PID, no?
PID, pelvic inflammatory
Is it?
disease.
Okay.
Yes, ma'am.
Why do you ask for loss of appetite? Loss of weight and
If
loss of
it's
appetite?
associated with any malignancies,
Okay.
estrogen secreting tumors can cause, but it's very rare.
So will cause loss of weight?
No.
Okay.
Ma'am, endometrial carcinomas
Yeah. So
is
you're worried about
common in this age group.
Yeah, but endometrial carcinomas, weight loss will be at very late stage, isn't it? Ovarian and endometrial. So I was thinking you're thinking of tuberculosis. That's what I thought.
Tuberculosis is also common in India as well.
Okay, next, continue.
1 second, ma'am. Can I ask, ma'am?
Yes, sure.
What type of fibroid will cause intermenstrual bleeding? Because in your history, you have told me.
Yes,
Yeah.
ma'am. Submucous fibroids can cause intermenstrual bleeding, ma'am.
Submucous fibroid. What? One more sentence you have to add.
It's
One more
polyp.
word.
Submucous polyp.
Yeah, submucous
And
polyps.
whenever you ask history of intermenstrual bleeding, that should automatically be followed by history of postcoital bleeding,
Yes,
because
ma'am.
they can coexist. Not necessary always, but that should also figure in your history taking. Okay, history of contact bleed or history of postcoital bleeding.
Postcoital
Okay.
bleeding.
Yes,
Okay.
ma'am.
One question. In your patient, what type of menstrual abnormality this patient? What are all the types? You said the cycle.
There's menorrhagia, excessive flow.
What is the newer terminology for menorrhagia?
New heavy menstrual bleeding, ma'am.
Okay.
Okay. Then, so the flow volume is more. Then what is the frequency you said about?
She's going prolonged cycles, no?
Prolonged cycles, ma'am.
Yes.
The normal frequency is
It is called infrequent. Okay.
ma'am,
Infrequent cycle.
infrequent cycles.
The cycle duration is long. Then any other abnormality? What is the duration of
Bleeding.
flow?
The duration of flow is also increased, ma'am.
Long.
Normally around 5 to 7 days.
So you have the abnormal frequency, abnormal duration, as well as the
Duration.
volume, and also intermenstrual bleeding also.
Yes, ma'am.
So, madam was telling about the spasmodic dysmenorrhea. Since submucous fibroid, the patient sometimes may have severe pain. What could be the cause? And relieved after some time. Submucous fibroid.
Infectious cause, ma'am.
No, infections will not cause pain as such, right?
Because usually, what is myomatous polyp?
Myomatous polyp is when the peduncle, the submucous fibroid protrudes into the uterine cavity
Yes. So when
and descends.
polyp, it is severe, the patient has severe dysmenorrhea, spasmodic pain. Okay. Okay, you can proceed. Next. So from the history, what is your probable diagnosis of the history of present illness?
She has probably a submucous fibroid, ma'am.
Any other? But why then the cycle?
Endometrial hyperplasia can be there. Associated with endometrial.
Cycle once in 60 to 70 days now.
Yes, ma'am.
In other words, madam is asking what are the causes of menometrorrhagia, heavy menstrual bleed plus intermenstrual bleed. You tell us all the causes, Dhamma.
Endometrial polyps. Hyperplasia associated with cervical polyp, fibroid uterus, which has intramural fibroid and submucous fibroid, or submucous fibroid alone can cause heavy menstrual bleeding and intermenstrual bleeding.
Yes. Okay. So now is that is AUDO also can be associated.
Yes, isn't it?
Okay,
So don't
so-
think of only palm, like, even the ovarian. They may not be fibroid at all. She may be having some ovarian cause. You think it's ovular and anovular?
It's anovular, ma'am.
She has severe pain, no?
Yes, ma'am, but that pain can be because of the fibroid.
No, it can be ovular also, no?
Ovular.
Maybe once in 60 days, but it may be ovular, right?
Yes, ma'am.
Okay, continue. So she's having urinary symptoms also along with that.
Yes, ma'am.
Okay. Urgency, frequency, and voiding. So what do you think it may be?
It's a large fibroid, ma'am, submucous fibroid, which compresses the urethra, ma'am, anteriorly. Or it can be a lower anterior fibroid, which is huge, associated anterior fibroid compressing the urinary tract.
Urinary symptoms are common with which fibroid?
Anterior fibroids, ma'am.
Which one? Body, cervix, fundus?
Cervix.
Cervical.
Cervical anterior fibroids, ma'am.
Yeah, okay. Not necessarily anterior, even posterior also. Posterior sometimes may push the
Compress the uterus towards.
Yeah. So. Okay, continue. Which drugs you're worried about? Just go back. You said no history of drug intake. Which drugs
Yes,
can
ma'am.
cause heavy menstrual bleed?
Anticoagulants, is she on any aspirin, or
Yes.
is she taking drugs like antidepressants which interfere with the HPO axis?
Okay. Continue. Continue. Yeah.
Yes, ma'am. Marital history, she was married at the age of 15 years. Her husband died 15 years ago. She's sexually inactive for the past 15 years, ma'am.
Okay.
Obstetric history, parity 1, living 1, one male child of 28 years old, delivered by full-term normal vaginal delivery. It was a home delivery. He's alive and healthy. Personal history.
After that, what happened?
Ma'am?
Just go back. She delivered 28 years back.
Yes, ma'am.
She lost her husband 15 years back, right?
Yes, ma'am.
The 13 years, what happened?
13 years, ma'am.
13
years
years,
she didn't get conceived, ma'am. She didn't take any treatment also to get
Okay.
conceived.
So she had secondary infertility.
Yes, ma'am. Which she didn't go to the hospital for treatment also.
Okay.
Personal history, mixed diet, adequate sleep pattern, normal bowel habits, no history of betel leaf chewing or smoking or alcohol. She's a known hypertensive patient for the past 6 months. Not a known case of diabetes mellitus, bronchial asthma, seizure disorder, heart disease or thyroid disorder, or any history of tuberculosis in the past. No history of any other drug intake or hormonal usage. No history of any drug allergy. No history of blood transfusions in the past, or history of any treatment for the present illness in the past. No history of similar complaints in family members. No history of bleeding disorders in the family members, or history of any carcinoma in the family members. General examination, she's well built and nourished. Pallor present, no pedal edema, cyanosis, clubbing, and significant lymphadenopathy and icterus were absent. Height 158, weight 80, her BMI is 32. She falls under obese category. Vitals, temperature normal, BP 130/90 millimeters of mercury, pulse rate 98 per minute, thyroid normal, bilateral breast examination normal, gait and spine normal. Systemic examination, CVS S1, S2 heard, no murmurs. RS normal vesicular breath sounds heard, no added sounds. CNS, no focal neurological deficit. Per abdominal examination, inspection, abdomen was scaphoid, umbilicus in the midline and inverted. All quadrants of the abdomen moves equally with respiration.
One
Yes.
second. She was an obese woman and her abdomen was scaphoid, is it?
Ma'am,
BMI was something like 32, right?
32, yes, ma'am.
Okay. She had scaphoid abdomen.
The lower
I'm just
abdominal
asking.
wall.
I'm just asking.
Abdomen also obese, no? Abdomen wall.
Obese,
Yeah. Okay.
Okay, after the general examination, any diagnosis you more in favor of she's obese,
Yes,
hypertensive,
ma'am. Yes, ma'am. Endometrial hyperplasia might be there.
endometrial causes.
Yes, ma'am.
Okay, AUBM. Okay, that can be. Okay. Proceed.
Okay.
No obvious mass or swelling. No visible sinuses or dilated veins noted. No scar. Hernial orifices were free. Palpation. Per abdomen soft, not tense or tender. Umbilicus is in the midline and inverted. All quadrants of the abdomen moves equally with respiration. No organomegaly. Hernial orifice is free. Percussion. No fluid thrill or shifting dullness noted. Normal resonant bowel sounds percussed. Auscultation. Normal bowel sounds heard. External genitalia examination. Mons pubis, labia majora and minora appears normal. Pubic hair appears normal. No obvious swelling or mass noted. Perspiculum examination. An elongated fleshy polypoidal mass of size 8 × 5 cm seen protruding through the external cervical os. Bimanual pelvic examination. Elongated fleshy polypoidal mass of 8 × 5 cm seen protruding, felt protruding through the external cervical os, which bleeds on touch. The stalk could not be traced. The cervical lips felt all around the polypoidal mass. Uterus anteverted, uniformly enlarged, 14 week size, which was mobile and non-tender. Bilateral fornices were free. No fornicel tenderness or fullness. Rectal examination. Rectal mucosa free. No nodularity felt. Summary, ma'am. 44-year-old perimenopausal lady with parity 1 living 1 presented with complaints of heavy menstrual bleeding for the past 1 year, whose previous cycles were regular. On examination, she had pallor with stable vitals. Bimanual pelvic examination revealed a 14 weeks uniformly enlarged non-tender uterus with a polypoidal fleshy elongated mass of 8 × 5 cm protruding through the external cervical os, which bleeds on touch. A case of AUB for further evaluation. My probable DDs are AUB SM submucosal fibroid polyp with associated endometrial hyperplasia.
Yeah, so straight away it's written, no? Diagnosis is written there, AUBP, right? Polyp. Okay, any doubts? No. Yeah, okay. So what's your diagnosis?
My diagnosis is the patient has submucous fibroid polyp which protrudes outside the os with associated endometrial hyperplasia.
No, endometrial hyperplasia, clinically, how did you make out?
Clinic, by
Yours
the
is clinical
history
diagnosis,
alone.
right? Yours is clinical diagnosis, right?
Yes.
Why do you say it is a fibroid polyp?
And because it arises, the stalk could not be traced and the cervical lips were felt all around the mass. So it's of uterine origin, the polyp.
What is other polyp?
Endometrial polyp is also there, but it can't be, endometrial polyps usually don't be this huge, ma'am.
No, not endometrial polyp. Anything from the cervix. From the cervix polyp.
Cervical polyps.
Cervical polyp. How will you differentiate cervical polyp and myomatous polyp? Clinically.
Clinically, cervical polyps, the stalk will be attached to the cervix, ma'am. It will be seen. The origin, the site of origin can be identified in cervical polyps.
It is a mucous polyp. No,
Mucous
from the
polyp.
cervix. And what is the appearance? Clinical appearance. When you put the speculum,
Ma'am?
when you put the speculum, you will see that it is a, what is the color? What is the? It is typically it is a reddish
Pink.
elongated. No, elongated. You said it is also elongated, but it's myomatous polyp is more or less globular. Anything else? Any other difference? Okay, you can see the pedicle attached to the cervix, but the myomatous polyp pedicle may not be, cannot reach the pedicle. Okay. And the surface will be
Smooth.
How is surface appear? Why it occurs?
Cervical polyp surface will be smooth, ma'am.
Hmm.
Endometrial, the fibroid polyps, it will be globular.
Okay, so this is the endometrium, thinned out endometrium get infected because of the exposure as well as infection. So it that is the cause for where intermenstrual bleeding.
Bleeding.
Okay. So even postcoital bleeding or any contact bleeding they will have. Okay.
Okay, so how do you want to proceed further with your case?
And basic investigations,
Mhm.
complete blood count, thyroid profile, RFT, LFT function, blood grouping, to rule out any bleeding disorders.
Do you want to rule out bleeding disorders in her?
No, ma'am, not in this age group.
Okay, so what is the investigation you will do for her now?
Ma'am, the investigation for?
For this patient, yeah, if I ask you to do.
For the diagnosis.
For the diagnosis, CBC, TFT, RFT,
No,
LFT.
the investigation.
Ultrasound for her.
Ultrasound,
You do ultrasound or no?
Ma'am,
You do
ultrasound abdomen.
Yeah, you have to do ultrasound. For what you want to do ultrasound? Tell me. What are the details you want to know?
Ma'am, the uterine contour, the how many fibroids are there, the origin of the fibroid,
Okay.
and the endometrial thickness, if possible.
Yes.
Any adnexal masses.
So all these details you want to know, right?
Yes, ma'am.
Yeah. Okay. So then continue.
After ultrasound, if possible, I would like to take a endometrial biopsy, but since the polyp is huge, not able to do so.
So what will you do?
Polypectomy proceeded by biopsy.
Polypectomy. How will you do the polypectomy?
Vaginal polypectomy.
So that how will you do it? You're not able to see the stock, right?
Okay, yes, ma'am.
Under what guidance you will do?
Hysteroscopic guidance, ma'am.
Okay.
Hysteroscopic guidance, polypectomy.
See, like you said, the polyp is totally outside the cervix, right?
Yes, ma'am.
Yeah, you're not able to see the stock.
Stock.
Yeah. So what will you do? Practically, how will you go about it?
Abdominal
Before inserting the scope, what you have to do that in order to insert the scope itself, what you should do?
Ma'am, to reduce the size of the fibroid, medications, free of medication.
You want to do all that for this case, which is lying outside. It's lying outside the cervix, right?
Yes, ma'am.
So why you want to give medications and reduce the size? How will you remove the polyp? You have seen no polypectomies you have seen, right?
Yes, ma'am.
Have you heard of avulsion that you tell?
Twist it and avulse.
Yes.
Yes, ma'am.
Yes. Okay. That's one method. Otherwise, what you can do, you can drag it in wherever you see the stock, you can apply a clamp. Then remove this. Then later you can remove the stock by using your hysteroscopy and all that, isn't it? Does it make it easier or difficult? That's more easier, right?
Easier, ma'am. Yes.
Yeah. You can tie the stock, then put in a scope and see where the pedicle is attached, and later you can remove, isn't it?
Yes, ma'am.
Yeah.
The cervical mucus polyp can be twisted and removed, but myomatous polyp put a clamp as high as possible and ligate it and
then remove it, and maybe you can tie it up and then go do a hysteroscopy and see wherever is attached and remove the stock, isn't it?
Yes.
And along with that, you can do an endometrial
biopsy,
isn't it? Okay. So she has this one polyp. Then you said uterus is 14-week size. There are some more fibroids inside. What do you want to do?
Imaging, ma'am, to find out the location and type of fibroid, whether it is intramural. Then identification of the size, approximate identification of the size. If it is huge, Then we can plan for pre-op medications to decrease the size.
No, yours is 14 weeks. The uterus is
14
14
weeks.
weeks size. Yes. Yeah.
Formally enlarged.
And then proceed with hysterectomy, ma'am, if the patient is willing, not willing for hysterectomy.
Come again.
And to proceed with hysterectomy, if the patient doesn't want the uterus, she's willing for hysterectomy.
Okay, so you have to know the location of the fibroid. Suppose
That's right.
there's only submucous fibroid along with polyp, then
We can give her the option to continue medications also, ma'am.
you can same sitting you can do polypectomy and as well as myomectomy, you know, histoscopic myomectomy. Can't you do?
Yes, ma'am. Hysteroscopic myomectomy can be done.
So depends on the size of the fibroid,
it-
number of fibroid, location also. Suppose it is only polyp plus submucous fibroid, you can complete the procedures with histoscopy itself, right?
Yes, ma'am.
Yeah. Otherwise, can't you do in non-distant vaginal hysterectomy after polypectomy?
Non-descent. She had a one full-term normal vaginal delivery, 14 week size. We can give her the option, ma'am.
You don't give it the option. You have to decide about the route, right? You
Yes,
can't.
ma'am,
The
we
patient
can.
will not know which route is better, right?
Yes, ma'am.
You should decide the route, right?
Yes, ma'am. Non-descent vaginal hysterectomy can be done.
Yes. So for that, if you want to do a hysterectomy, how will you assess? So your polyp size you have assessed. Suppose you want to do vaginal hysterectomy for her, what are the parameters you have to assess?
The uterine size in weeks, it should not be more than 16 weeks of size.
Okay.
And the fibroid size should be less than 4 centimeters. Should not be so huge, ma'am. It should be less than.
This is only 14 weeks, right?
Yes, ma'am.
Yeah. Okay. What are the other
Size
parameters?
is not the fibroid, uterus size only. Okay.
So your uterus size is 14 weeks, right?
Yes, ma'am.
Yeah. What are the other things? Like you usually do trial and see whether it's going to come down, isn't it? For vaginal route. So what are the other parameters you have to assess to say that I can do a vaginal hysterectomy?
Is there any, if the uterus is mobile or not, is it any fixed to the adjacent structures?
Okay. Yes. Transverse diameter.
Transverse diameter.
How much? Of course, now even bigger than that, we can morcellate and do bisect and do hemisection and all that. But ideal is how much?
8 centimeters.
Yeah. Yes, you're telling the answer. They say
8
like,
centimeters.
yeah, 8 centimeters will be ideal. But of course, we can go ahead with morcellation, hemisection. Nowadays, we do bisection and still we can remove even bigger uteri. Okay. Just for the theory sake, you have to know all these points. Okay. Yeah. So you can decide on polypectomy followed by hysterectomy or polypectomy and myomectomy. So depending on the location and size of the fibroid, right?
Yes, ma'am.
Yeah. Okay. Suppose she says she wants conservative. You remove this fibroid, you remove this fibroid polyp. She has 1 or 2 more fibroids inside.
If she wants conservative, then we can go for medications, ma'am, first to reduce the symptoms and the size of fibroid.
Okay.
We can give her non-hormonal medications like tranexamic acid, mefenamic acid and all. And to regularize the cycles, we can give her progesterone-related medications like oral pills or injectables or LNG IUS if there's no intracavitary, intracavitary distortion. And
so what is the, suppose, what is the recommendation of progesterone dose? Suppose you think you remove this fibroid and she's got endometrial hyperplasia without ATPR. Okay. Yeah. So then what will be your medical line of therapy?
And medical management with progesterone pills like medroxyprogesterone acetate.
You have to tell the dose, duration, everything.
Yes, ma'am. Norethistron can be tried 5 to 10 mg.
You would prefer norethistron or medroxyprogesterone?
For the patient's convenience, medroxyprogesterone can be given.
It's for convenience or like it has got an indication? When do you give norethistron? In which patients you would prefer to give norethistron?
Norethistron.
And which patients you would like to give progesterone?
Anovulatory cycles patients with endometrial hyperplasia. When the endometrium is already primed with estrogen, when you know.
Then you
and
can give both. No? You can give norethistron is what?
norethistron is progesterone, ma'am.
What is methoxyprogesterone?
That's also progesterone.
What is the difference between these two?
Metroxy. It's injectable, ma'am. No,
Hey,
no,
no, no, no.
no, 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 no. Sorry,
What are
sorry.
oral?
Sorry, ma'am. That's depot metroxyprogesterone.
If the patient is young, which one would you like to give?
Huh?
Younger patients? Which
Younger patients. Younger patients, norethistron can be.
Yes, why? Especially puberty menorrhagia, young patients
yes,
with heavy menstrual bleed, you would like to give norethistron.
Norethistron.
Because those who are around perimenopause, you would like to give medroxyprogesterone, right?
Yes, ma'am.
So what is, you should know what is the effect of both. Okay.
Yes.
Okay.
Endometrial hyperplasia, medroxyprogesterone is indicated. So how long you give without ATP? Suppose the report came as endometrial hyperplasia without ATP. How will you follow?
Ma'am, we have to give medroxyprogesterone acetate for 3 to 6 months duration and repeat the biopsy to see if there's any ATPR.
Will you give continuously or cyclically?
Ma'am?
Cyclically,
ma'am.
Not, no. Should be given
Which is
continuously.
better? Which is better?
Continuous treatment is better.
Continuous is better because if you want the hyperplasia to come down, better to give continuous.
Continuous.
Yeah. What is the dosage?
The dose is 20 to 40 milligram.
We are in between that. In between 20 and 40 is what?
30, ma'am.
Okay. So ideally 30 milligrams at least.
30
minimum. Yeah. Okay. So you put her on continuously. Okay. So what will tell you that she's not responding? You put her on continuous progesterone.
Yes, ma'am.
And what will tell you that she's not responding? What symptoms may tell you she's not responding?
If she's not having her menstrual cycles,
means she's not acting. You'll be worried if she has a menstruation or if she doesn't have menstruation when she's on continuous progesterone.
When she's on continuous progesterone, we'll be worried if she has menstruation. Sorry, ma'am, because of the breakthrough bleeding.
Yes. If she has, despite this, if she has bleeding, then you should think that she is not responding to therapy.
To the steroid, progesterone.
Okay. Madam asked some questions, so just reply to madam. No?
How long you give and how will you follow up the patient without ATP?
Without ATP for 3 to 6 months, we can give, ma'am, followed by a repeat biopsy, endometrial biopsy, to see if she has developed any further ATPR and to reconfirm whether the hyperplasia has reduced.
Most of the hyperplasia without ATP regresses. Okay. So it's present same report has come, same report. What will you do? What advice you give? She's 44 years.
We can give her the advice for hysterectomy, ma'am.
Yes. Okay. So, will you, endometrial biopsy, what are the patients who want to take endometrial biopsy with the AUP, not this patient? Suppose a patient comes to you with the abnormal uterine bleeding.
Yes, ma'am.
Advice
PCOS patients, polycystic ovarian syndrome patients.
First age, which
age? Perimenopausal group, 40 years and above. Patients having anovulatory cycles.
Okay, 40 years and above, all patients, if they have abnormal bleeding for more than 6 months. Less than 40, what are the indications that you are telling? No?
Yes, less than 40 PCOS, obese patients. those having anovulatory cycles,
Those
taking
who are high risk for endometrial carcinoma. Okay.
What is the cutoff of endometrial thickness for younger patients?
4 mm in
Oh,
Oh,
younger
younger
patients.
patients. Younger
For
patients.
younger
Young
patients.
Yeah.
Younger patients, 12 mm.
Yeah. More than
12
12
mm.
mm only is an indication for endometrial biopsy. Less than that, you need not do a biopsy. So postmenopausal cutoff is 4 mm, right? Madam asked some question, no, where will you take biopsy from something? Something. No, ma'am?
No. How will you take the biopsy? What method you use? Prefer.
Hysteroscopic guided biopsy, ma'am.
For all
Endometrial with pipple we can take, ma'am.
Okay. So, yeah, for all
Or
patients,
dilatation
it's not possible. Okay. Pimples. Okay.
with pipples.
How will you
Or
do? Have you done? How will you do
yes, ma'am.
endometrial biopsy?
It can be done in an OP basis, ma'am. Under sterile aseptic precautions, patient in lithotomy position. First PV done, then a speculum examination. With the pipple is introduced inside the os, external cervical os, and taken. The biopsy is taken.
You'll take from external os, sir.
It's introduced inside. The instrument is introduced inside the external os.
Go up to the
the fundus, till the fundus.
You will insert into the uterine cavity, right?
Yes, ma'am.
Yeah.
Dilatation.
When you do hysteroscopy, suppose you are done and hysteroscopic guided biopsy when it is indicated.
Hysteroscopic guided biopsy.
Will you do DNC? Fractional curettage, DNC?
Dilatation and curettage can be done.
But nowadays it is not recommended. You can do a people's biopsy OP procedure. If it is not, that is a report is, it is not adequate, or if it is contradictory to the ultrasound finding, then you have to go for hysteroscopic directed.
Hysteroscopic guided biopsy can be both diagnostic and therapeutic also.
Yes.
Any other intracavitary lesions can be seen if it is done.
So you can take a guided biopsy, isn't it?
Yes.
So you can take from suspicious areas. Okay. Yeah. And even small polyps can be treated if it's there simultaneously. That's the advantage of taking hysteroscopic guided biopsy. Okay. Suppose the report comes as ATPR.
Yes.
Then what do you do?
We give her hysterectomy has to be done, ma'am.
What type of hysterectomy you will do?
Total abdominal hysterectomy.
Okay. Regularly, what type of hysterectomy you do?
Regularly.
Intrafacial or extrafacial?
What type of
You
hysterectomy?
do intrafacial or extrafacial hysterectomy regularly?
What we are doing
Intrafacial.
regularly.
Intrafacial.
Yes.
Intrafacial hysterectomy.
Yeah. What is the difference between intrafacial and extrafacial?
How the clamps are.
The clamps.
What is the difference between intrafacial? What do you understand by intrafacial and what do you understand by extrafacial hysterectomy? Which fascia you're referring to? Around the cervix. Which one? So normally after separating the bladder for benign lesions, what do you do?
After separating the bladder, the cervix is.
Suppose you're doing abdominal, you open the UV fold, you push the bladder. Next, what you will do?
Which clamp, which structure you clamp? Madam is asking.
So would you do separate fascia, pubocervical fascia? Do you separate or no for intrafacial?
We separate, ma'am.
Yes. And posteriorly?
The uterosacral.
Yeah. Before that, do you skeletonize and push the fascia away?
Yes, ma'am.
Yeah. So to avoid ureteric injuries, you do all that, isn't it?
Yes,
So
ma'am.
what is the importance of that fascia? What runs there? Yes.
Ureter. Ureters are close to it.
Lymphovascular, that's called a lymphovascular spaces. Lymphovascular space, that is, okay. So if you want, suppose you suspect some lesions like atypia, or you're little doubtful about your diagnosis, then better to do extrafacial hysterectomy where you don't separate the fascia. Okay, so that you remove the lymphovascular system also, which is around that. Okay, so if you're doing purely for benign, you can separate that fascia and do intrafacial hysterectomy. Okay, especially stage 1 endometrial carcinoma, very early, isn't it? Or even cervical. Early stages, they say carcinoma extrafacial.
Extrafacial hysterectomy. Okay.
Yeah. Okay. Yes. Yes, ma'am, you can ask the questions.
Oh, you have done ultrasound. The role of ultrasound and AUV, which ultrasound you do? Is it transvaginal, transabdominal, or both?
Both can be done, ma'am.
Both should be done. First,
Both should be done.
abdominal, then vaginal. Okay, how will you, these patients, your patients have uniformly enlarged 14 weeks now.
Yes.
So there's no other fibroid except the submucous becoming a polyp. What could be the cause for the size 14 weeks?
The probable DD is she can have endomyometrial hyperplasia, or that can be adenomyosis also, since the uterus is enlarged.
Okay, so ultrasound, can you differentiate, diagnose adenomyosis?
Yes, ma'am. There will be loss of endomyometrial junction, and there will be cystic lesions inside the myometrium. And
vascularity?
Vascularity will be diffuse, ma'am. Vascularity will be seen.
Subendometrial linear echogenic rays, no? That is sunray appearance. Then, what is the symmetry? That is whether the anterior and posterior wall or myometrium. How it appears. There are so many 6 to 7 points. At least 3 should be present to diagnose adenomyosis. Okay.
Is the same? Both anterior, posterior, same or something different?
Anterior myometrium and posterior myometrium, asymmetry is very common. Okay.
Which one is more? Which one is more thicker?
Anterior myometrium.
Posterior. Okay.
Yeah. Posterior is thicker. Okay. What is, how can you differentiate adenomyoma and fibroid or myoma?
Yes, ma'am. Fibroid in ultrasound, it appears a hypoechoic, well circumscribed round mass. Adenoma, and if you put Doppler, the vessel will be in the capsule, ma'am, in case of a fibroid. In adenomyosis, it is in adenomyoma, it is hyperechoic, and color uptake in Doppler will be diffuse, ma'am.
It's not well defined.
Not well.
So, when we that is suspect sarcomatous changes in a fibroid, clinically by ultrasound or cut section?
Clinically, the patient will have symptoms like loss of weight, loss of appetite.
No. That is all in late stage.
Already having fibroid, so when you suspect some malignant change or sarcomatous change.
When the patient will have pain, severe pain.
Yes.
Then what happens to fibroid?
Increase in size.
Fibroid.
Is there a sudden increase?
Sudden increase in size, ma'am. Sudden increase in mitosis, so sudden increase in size.
Okay. Pain, sudden increase in size, then?
Okay. Then how will you confirm ultrasound findings? Same thing, no? That is it is not well defined. The capsule will be absent, so that it's not a well defined tumor. Increased blood flow by Doppler. Okay.
Altered echogenicity, vascularity, all that you have to speak about. Okay.
Suppose you have done a hysterectomy for a fibroid. How will you differentiate between fibroid or a sarcoma? Sarcomatous changes of fibroid. When you cut section.
The world appearance will be lost.
Very good.
Okay.
Sometimes it will be associated with a foul smelling odor.
Consistency, variability, appearance,
Appearance.
vascularity,
Soft,
all
friable, no?
isn't it?
The pinkish white pearl appearance will be last.
White pearl.
Okay. Again, ultrasound. Any other procedure you can do through ultrasound to differentiate between a polyp, endometrial polyp.
Saline infusion sonography can be done, ma'am.
So you can differentiate submucous fibroid and endometrial polyp. Okay.
What
How
will be
will
the
you
difference?
How will you differentiate? How will you differentiate endometrial polyp and submucous fibroid?
In saline infusion sonography, ma'am.
Yes. Because ordinary ultrasound may be difficult. Huh? If you know the anatomy, that is, if you know the pathology. The polyp comes from endometrial polyp is
From the endometrial surface. So
it is adenomatous, that is the glandular enlargement.
Glandular.
So it is the endomyometrial interface will be retained. It is protruding into the
cavity.
endometrial cavity. So you can even see the pedicle, the vascular pedicle. When you put the saline, it is well appreciated. Okay. For submucous or the submucous fibroid it is the endomyometrial interface is altered. Okay. The thinning of the endometrium and it is pushing into the endometrial cavity. So this is very important investigation to differentiate. Cis or saline infusion sonography. Okay. And also sometimes ultrasound, 2D ultrasound may be difficult to differentiate endometrial hyperplasia and a polyp. So when you do cis, you can easily differentiate. Okay.
Okay. So suppose this fibroid was sitting near the os, it's not coming out, it's sitting near the os. Okay. How do you, I say it is inversion of the uterus. How do you differentiate? It is at the level of the os, not come out. So you can't make out whether it's a polyp or not. Then I say it's inversion, chronic inversion.
Ma'am, per abdomen, transabdominal ultrasound can differentiate.
Oh, clinically, what all you will see?
Clinically, the fundus of the uterus won't be able to palpate if the uterus is enlarged and
But
has
what
an
will be the
inversion.
appearance? What is the difference between polyp and inversion? Appearance. Polyp will be how?
Polyp will be fleshy.
Pale, no? Pale white, right?
Pale white.
Yeah. Does it bleed?
Yes, ma'am, it bleeds on touch.
Polyp. Fibroid polyp. Does it bleed on touch?
Fibroid polyp doesn't bleed.
Yeah. So that is the difference, no? Fibroid polyp and inversion, right?
Inversion.
Yeah. What will be the inversion? What is the layer you're going to see in inversion?
The endometrial layer will be.
How it will appear to look?
Red.
Yeah. So it is more reddish.
Reddish.
Does that bleed?
It bleeds on touch.
Then next year, bimanual examination. How will you feel?
Bimanual examination won't be able to make out the fundus of the uterus.
Okay, so that's the difference. You won't be able to palpate the fundus at all. It will appear just small, isn't it?
Yes.
So that's how you differentiate. Then of course, ultrasound is definitely going to help you. So suppose it was inversion, what will you do? No, it's not. It's out of this topic. Suppose you know your answer. Otherwise, it is okay.
If it is inversion, we
It's
can
a
do
chronic inversion.
chronic inversion, not
So what will you do?
non-descent vaginal hysterectomy.
It's very difficult to do. Where will you go, clamp, cut and all that? Yeah. You can do, but how will you go about it? You have to separate all that, no? Layers, different layers you have to separate. UV fold and all that. Is it easy in chronic inversion to get all that?
No. Ma'am, we can reduce. Can we reduce the inversion, ma'am?
Yes. So you can reduce the inversion. So will it just move up like that? How will you reduce?
We try try to reduce it by bimanual examination or inflate a balloon. Reduce
Like
it.
the Bible. It's not so easy, chronic inversion. Yeah.
Chronic inversion only surgery.
Yeah. Okay. So there are various surgeries. Okay. So
Yeah.
that will be that. Anyway, that was out of this. Okay. Here, suppose you want to do a pap smear. How will you do in this case? There's a polyp sitting there. You want to do a pap smear.
After polypectomy, we can do a pap smear, ma'am.
So you'll do polypectomy and then do a pap smear. Right.
Yes, ma'am.
Yeah. Otherwise, before polypectomy. This was a stock, no? This has come out.
It has a stock. We can clamp it and. Or the pap smear can be taken around the stock of the
You can
polyp.
take, isn't it? You can take around the stock.
Around the stock of the polyp.
All you want is a transformation zone, right?
Yes, ma'am.
Yeah. So you take the transformation.
Can I ask that?
Yes, ma'am. Sure.
What is the relationship between endometrial polyp and fertility?
Endometrial polyp, if it doesn't allow the sperm motility, if the polyp is descending through the os, ma'am, physical obstruction or
No, small or not. If it is large, okay. Even if they are small and multiple small endometrial polyps, they can interfere with implantation and increase the rate of miscarriage. Okay. Okay. How will you manage? Supposing it's an asymptomatic endometrial polyp. It's not symptomatic like your case. If she is a premenopausal woman and she's got an asymptomatic polyp, how will you manage? Premenopausal. Menstruating lady, asymptomatic polyp. You just picked it up on the scan on your TVS. So what will you do with her?
if she wants the polyp to be removed, then hysteroscopy guided polypectomy can be done.
She says, doctor, you decide. She's not educated enough to take the decision on her own.
We can give her the medical managed asymptomatic.
So up to what size you can do, you can keep her on observation. Up to what size you can keep her on conservative management. When the polyp is less than 1 centimeter and asymptomatic, you can observe her. Okay, if it is more than 1 centimeter, you need to remove it. Okay, if she's a postmenopausal woman and it is an asymptomatic polyp, what will you do? Postmenopausal, same scenario, but postmenopausal lady, asymptomatic polyp.
We have to remove it and
you have
send it
to
for biopsy.
You have to do a hysteroscopic
Guided polypectomy.
Polypectomy. Yeah, she needs evaluation. Okay. Can you tell me the risk factors for developing endometrial polyps? Basically, your case is endometrial polyp or AUBP, isn't it? So tell me, what are all the risk factors for developing polyps?
Increased exposure to estrogen.
Okay.
Obesity. PCOS. Age.
Diabetes.
Hypertension.
Then, what drugs? One particular drug which is used for CA breast.
Tamoxifen.
Tamoxifen. Okay. And then even your hormonal replacement therapy, continuous use of estrogen. So all these patients are high risk for developing endometrial polyps, and so you have to watch. Thank you, ma'am. Thank you for that.
No. Yeah. Okay. Subha ma'am, you want to ask anything? You can ask. You're muted, ma'am.
One more case is there. I think. One more
case is there.
Ma'am,
okay. There's one more case is there.
Dr. Felicia.
Okay, doctor. Then present that case, no, briefly. One more case.
And Dr. Felicia is our just first year student.
Yeah,
Okay.
she can put it as a small.
That's no problem.
Yeah. Summarize and present as a short case.
Yes.
Thank you, ma'am. Thank you.
Sorry.
If they are ready with the case means let them present. No problem.
Yes, ma'am. Yes, ma'am.
Yeah, you present.
Dr. Felicia present.
Yes.
Thank you, ma'am. Good evening, ma'am.
Sheila, did you understand the intrafacial and extrafacial?
Yes, ma'am. Yes, ma'am. Thank you.
Not the exam. Whatever you have the doubts, you can clear it.
Yeah.
Okay, ma'am.
You are clear now. We understood, no?
Yes, ma'am.
Yeah. Okay.
Thank you, ma'am.
Okay. Yeah, Felicia present. You unmute yourself, Felicia.
Good evening, ma'am.
Yeah, good evening. Yeah, go ahead.
Thank you for this opportunity, ma'am. I'm presenting abnormal uterine bleeding.
Yeah, go ahead. Yeah.
Mrs. Selvi, 40 years old, from Omalur, Salem. She's a housewife by occupation and belonging to class 2 socioeconomic status. Para 2, life 2, previous 2 normal vaginal delivery, sterilization done. Last childbirth was 14 years back. Last menstrual period was 19 June 2022. Came with complaints of heavy menstrual bleeding for past 7 to 8 months. Patient was apparently normal 7 to 8 months back when she started developing heavy menstrual bleeding. It was regular, lasted for 5 to 6 days in a 28-day cycle. She changes 7 to 8 pads per day. It was associated with passage of clots. She also has history of EC fatigability. There was no history of dysmenorrhea, no history of intermenstrual bleeding or postcoital bleeding, no history of foul smelling discharge per vagina, no history of dyspareunia, no history of constipation and tenesmus, no history of breathlessness or palpitation, no history of loss of weight or appetite. Menarche was attained at the age of 13 years. Previously, she had regular 4 by 28-day cycles, changed 2 to 3 pads per day, not associated with passage of clots or dysmenorrhea. Her last menstrual period was 19 June 2022. She was married for 18 years, non-consanguineous marriage, and was living with her and is still living with husband. Para 2, life 2, ma'am. For first child, male child, 17 years back, normal vaginal delivery, alive and healthy. Second is a female child, 14 years back, normal vaginal delivery, alive and healthy, and puerperal sterilization was done 14 years back. On past history, not a known case of diabetes mellitus or hypertension or cardiovascular disorders or bleeding disorders. Sterilization was done 14 years back. Family history, no family history of diabetes mellitus or hypertension or thyroid disorder or cardiovascular disorders or bleeding disorders or malignancies in family. Personal history, she has a mixed diet. Sleep and appetite is normal. Bowel and bladder habits were regular and no history of substance abuse. On general examination, patient is moderately built and nourished. Height is 1.
From the history, any you come to diagnosis?
Ma'am, she has complaints of heavy menstrual bleeding for the past 7 to 8 months, and it is not associated with dysmenorrhea. There's a passage of clot, so there's abnormal uterine bleeding, and it could possibly due to adenomyosis or leiomyoma.
The cycles are regular, right?
Cycles are regular.
Yeah. So what do you think it is?
It could be AUBO.
Yeah.
It could be probably leiomyoma.
Regular cycle, no? Then how come O? You said O, no? AUBO.
Which type of cycles are in O? Which type?
AUBO is a regular cycle.
Yes.
Okay.
Could it be any coagulation disorders?
Yes, ma'am. Von Willebrand disease.
Then how will you know from the history?
Younger age group. Usually, von Willebrand disease will present in younger age groups.
Yeah.
No, in adult also. No? So what history will ask to know whether she has any bleeding disorders?
Any history of bleeding gums, epistaxis?
Yes. So this is a screening test. That is a history of, you have to ask that history to know whether she has any bleeding disorders. Okay, that is so certain points are there.
Bleeding gums.
Yes, bleeding gums, epistaxis, previous that is heavy bleeding since menarche. She has 2 children, no? Any PPH, like that. Okay, so many points are there. You have to read.
Okay.
So that is any one point. That is menorrhagia since menarche is 1 point. History of PPH, history of surgical related bleeding, dental work bleeding. Okay. Then the other things, that is epistaxis, gum bleeding. It's very important.
You have to rule out even thyroid disorders. Okay.
That is drug intake.
Around 40 years. thyroid disorders are common, which can present with menstrual disturbances.
Menstrual irregularities.
Okay. Continue with your examination.
Height 160 centimeter, weight 156 kg, BMI 21.87. Pallor present, no icterus, jaundice, cyanosis, clubbing, lymphadenopathy, or pedal edema. Breast, thyroid, and spine clinically normal. On vitals, pulse rate was 96 per minute, regular in rhythm and volume. BP 110 per 70 in right arm sitting position. Respiratory.
Yeah, you can skip this. You can.
Next slide.
Per abdomen and yeah.
On per abdomen, umbilicus and midline, all quadrants move equally with respiration. A subumbilical scar of about 2 centimeter noted and was healthy, probably puerperal sterilization scar. No dilated veins or visible pulsations. Bilateral hernial orifices normal, or orifices free. On palpation, abdomen soft, non-tender, no mass palpable, no guarding or rigidity. On percussion, equally resonant all over the abdomen, no fluid thrill or shifting dullness. On auscultation, normal bowel sounds are heard. On pelvic examination, inspection extern genitalia appears normal. On perspective examination, vagina and cervix appears healthy. Pap smear was taken. On bimanual pelvic examination, cervix pointing upwards, uterus anteverted, irregularly enlarged up to
See, all this pointing upwards and all, you'll see better or you'll palpate and see?
Palpate, bimanual exam, bimanual
cervix is pointing upwards. Vision is better or palpating is better?
Perspective vision.
Yes. So in perspective, you have to mention about the position of the cervix, all the details. Okay, like even if it's a short case, you have to write down cervix. It is how it is, whether it is multiparous os, nulliparous. How is the os? Which direction it's pointing. All that will tell you roughly about so many findings. Okay, so all those have to be described on perspiculum examination. Yeah.
Regularly enlarged up to 8 week size, mobile, firm in consistency, non-tender. Bilateral fornix is free, no cervical motion or fornical tenderness. On rectal examination, rectal mucosa free. To summarize, 40-year-old, para 2, life 2, belonging to class 2 socioeconomic status with previous 2 normal vaginal delivery, sterilized, having last menstrual period 19/6/2022 with abnormal uterine bleeding for past 7 to 8 months, presented with 8 week size irregularly enlarged uterus on bimanual examination. Diagnosis.
Probable diagnosis.
In case of 40-year-old, para 2, life 2, having abnormal uterine bleeding, probably AUB leiomyoma.
Okay. So how will you confirm your diagnosis?
I'll go for a transabdominal scan and a transvaginal scan for confirmation.
Okay.
On scan, like hypoequation.
Which type of fibroids give rise to these symptoms?
Submucous fibroid.
Yeah, most probably it may be submucous. Because it's a small one and only 8 week size, and she has heavy menstrual bleed, isn't it?
Yes, ma'am.
So you want to see the fibroid, then what else?
Then it's a complete blood count will be done to rule out anemia.
Okay.
Since she has history of heavy menstrual bleeding.
Mm-hmm.
Then TSH will be done to rule out any thyroid disorders.
Okay.
Then coagulation profile should be done to rule out coagulation disorders.
Okay. So you've done all that. Next, what investigation?
After that, dilatation and curettage should be done to rule out.
You want to do an endometrial biopsy, right?
Endometrial biopsy.
Yeah. Why you want to do endometrial biopsy?
To rule out endometrial carcinoma before.
So usually it is hyperestrogenic state, right?
Yes.
This is the fibroid indicates it's hyperestrogenic. So you want to rule out any pathology in the endometrium, right?
Yes.
Yeah. Okay. So you've done it and it's come as proliferative endometrium.
Perfect.
Ultrasound shows small fibroid about 3 centimeters, submucous and proliferative endometrium. Sheila also can answer.
Yeah, Sheila.
Both of you can
unmute and answer.
Yes, ma'am.
Yeah. First choice will be for Felicia. Then if she doesn't answer, Sheila can answer.
First, since the patient has heavy menstrual bleeding, ma'am, first we'll try for medical methods.
Okay.
tranexamic acid or mefenamic acid can be used to control the bleeding.
Okay. I told you the answer also. I said proliferative endometrium and a small fibroid, 3 centimeters fibroid.
What medication can you give?
Progesterone.
So if it's proliferative, you would like to give progesterone. If it is secretory, then you will think of giving all these antifibrinolytic agents, isn't it?
Yes, ma'am.
Yeah. So progesterone, what all forms you can give her?
Progesterone, levonorgestrone, medroxyprogesterone acetate can be given them.
Yes.
Then norethindrone.
Can you give her LNG IUCD?
LNG IUCD can.
Yeah, you can give, isn't it?
LNG IUCD.
Yeah, because it's a small fibroid. But if she wants conservative, you can always give even LNG IUS because very small fibroid. If the cavity is not a problem, then you can go ahead. Okay.
Yes.
If it is secretory, then you will think of giving
fibrinolytic agents like tranexamic acid or mefenamic acid.
Okay.
How it acts, LNG IUCD? How it reduces
Mechanism of action.
It will suppress the estrogen and progesterone. It will suppress estrogen and progesterone levels and cause endometrial neck.
itself progesterone, no? LNG is progesterone. Locally acting, stabilizes the endometrium and stops bleeding. Okay. Will it reduces the size of the fibroid?
Yes, ma'am.
Yes.
It will cause shrinkage of the fibroid.
It will stop bleeding, but the size is not much. Okay. It might not.
Okay, so no effect on the size of the fibroid as such. Maybe endometrial pathology, it may. Correct, right? Okay. What are the causes of bleeding in a fibroid?
Possibly due to the large surface area, due to the increased surface area,
Yes. Yes, Sheila, you also can answer.
And because of the decreased surface area and vascular fragility will be present, microvascular dilatation.
Okay. Associated endometrial hyperplasia, anovulation, hyperestrogenism.
Endometrial hyperplasia can be there.
Yes, ma'am.
Okay. What happens to contractility? Is it effective?
No.
No, isn't it? So congestion, endometrial hyperplasia, then increased surface, interferes with contractility, isn't it?
Okay.
All these cause excessive bleeding in a fibroid, right?
Yes, ma'am.
Yeah. Suppose it was a huge fibroid. You think it's 28-week size fibroid. What would you do?
20-week size fibroid. We'll have to consider total abdominal hysterectomy.
Okay. So if it's huge fibroid, also at what size? Suppose she was asymptomatic. This patient, of course, symptomatic fibroids you have to always remove. Asymptomatic fibroids, what is the cutoff of the size?
More than 12-week size we have to consider.
More than 12 to 14-week size. Yes. Okay. So that is the cutoff. Yeah. Ma'am, you can ask questions. Shubha, ma'am.
Yeah, the big size fibroid, not 28 weeks fibroid. What precautions you take during hysterectomy?
First, we'll reduce the size of the fibroid with medical methods. Before
what methods? You should tell, be specific.
GnRH agonists can be used to reduce the size of the fibroid.
Okay.
And this will also reduce the vascularity. So bleeding.
You're doing myomectomy or hysterectomy?
Hysterectomy.
Okay. So now you tell.
So, what are the precautions you should do for pre-op procedures? She's 28 weeks size fibroid. So you have to do an ultrasound KUB and also intravenous urogram.
Mentioned IVP Subha.
Yes, ma'am.
Ishwaran chat box la potrika IVP.
Okay.
What is the question, ma'am?
What is the precautions to be taken in a 28 weeks fibroid surgery? IVP, intravenous pyelogram, she has mentioned.
But
Then take-
IVP, see, you can do ultrasound and know whether there's hydroureter or not.
Yes.
But
but
IVP, how
will
it
do
is going to help?
last-
We don't know. It is not very helpful because how is it going to help? You'll do IVP and then it'll show something, but peroperatively that will not help you. You can't.
Ultrasound is enough. No
Yeah,
need.
ultrasound is enough.
KUB is
But you
mandatory
see-
for all.
Yeah, you have to locate and locate the uterus, ureter. When you see like doing a hysterectomy, you have to know where the ureters are.
And during that ultrasound KUB, if there is any hydrouretronephrosis or any compression, then we have to do an intravenous urogram. And then we can even do preoperative DJ stenting also.
Yeah, somebody has put, you can know hydronephrosis, but for surgery, your IVP may not help you because it will only say whatever is the location or whatever when you see on the X-ray. But peroperative, always you have to trace the ureters. If you find it is suspicious, uniformly enlarged uterus, you're not worried because
But
it could
irregularly
be X-rays.
enlarged, compressing the ureters.
Suppose there's a fibroid at the broad ligament fibroid or cervical fibroid or somewhere in the angular region, like especially near
Yes,
you.
even pseudo broad ligament fibroid. How do you differentiate, Sheila, between broad ligament fibroid, true and pseudo broad ligament fibroid?
True broad ligament fibroid, it arises from the connective tissues of the round ligament or broad ligament. And when it enlarges, the ureters and the vessels will be medial to the mass. In case if it is a false broad ligament fibroid, since its origin is from the uterus, the ureters will be pushed laterally.
Yes. What precautions while doing broad ligament fibroid, whether it's pseudo or true? What precautions you'll take when you're doing a broad ligament fibroid? This is for Sheila.
DJ stenting. We'll do a
Okay,
DJ stenting pre-op.
Okay, next.
The clamps, while applying the clamps, you should be careful.
So always you have to open the broad ligament. Okay.
Enucleate.
Mobilize.
Enucleate.
Okay. Try to enucleate or mobilize. Mobilize the peritoneum so that you mobilize the ureters also. Especially if you've done a uretic stenting before, you can palpate for the stents. Okay. Otherwise, you always your incision should be parallel. Don't cut transverse because you'll cut the ureters. Okay. So always in a clear area, make an incision and then separate the broad ligament and try to enucleate and then proceed. Okay. So you have to trace the ureters. That's very important. Okay. So large size uterus, if you're doing a hysterectomy, how do you prevent blood loss? What all precautions you will take to reduce the blood loss during hysterectomy?
On-table precautions, ma'am.
Sorry?
On-table precautions of
on table.
Ma'am, uterine artery embolization can be done.
Sorry, you'll do embolization and then go with hysterectomy, is it?
Uterine artery ligation can be done to prevent.
Okay. You want to remove the ovaries also here?
No, ma'am.
No. Okay. What else you'll remove along with the uterus? What else you will remove?
The tubes.
Why should you remove the tubes?
Chances of carcinoma, ovarian or malignancies are more, ma'am.
Okay, so they have found that the main causes for ovarian malignancies are?
Malignancies.
No, sometimes the patients gives history. So all patients will not remove the ovary or?
No, tubes, ma'am. Tubes.
Tubes remove. Sometimes the patient gives history, family history of.
Family history, yes.
Breast cancer or ovarian cancer.
No?
Will you remove? Our patient herself has a breast carcinoma. How to remove?
Prophylactic oophorectomy can be done, ma'am, if the patient has breast carcinoma.
Okay. Can you briefly tell me the steps of hysterectomy?
Huh?
Steps of hysterectomy.
Yes, ma'am. abdomen is SPT incision can be made and abdomen opened in layers.
Okay.
The uterus is identified and any external pathology is ruled out after opening the peritoneum. Then clamps are in. If we want to preserve the ovary, then clamps are made by cutting
Which is the first clamp?
First clamp.
tubes.
Which is the first clamp? Always.
Round
Which
ligament.
is the first? Yeah,
Round ligament tubes, then
First round
ovarian
ligament.
ligament. Round ligament.
Okay.
The round ligament tubes and the ovarian ligament. And if you want to remove the ovaries, infundibular pelvic ligament is ligated.
Okay.
And hysterectomy is proceeded. And
Next clamp. Next.
Proceeded how?
next clamp.
Next what?
Next,
Next
the McIntosh ligament.
How?
Before that. Next.
Okay. So
The UV fold. The UV fold.
reflect.
The UV fold is identified and the bladder is pushed down.
Okay.
After that, the McIntosh ligament, the
No,
uterosacral
next
ligament,
vascular pelvic.
vascular.
Is
The
what?
huh?
Next is what after UV fold? What is next?
The uterine vessels.
Oh. You took clamp the uterine vessels. Okay. Then next.
The uterosacral ligament, broad ligament.
Broad ligament is
No,
gone.
sorry, McIntosh ligament.
Okay.
Then if you want to remove with the cervix is
Normally you're removing with the cervix or routinely, or you're leaving the cervix behind regularly?
What should be done normally?
Regularly, what are you doing? You're leaving the cervix or you're removing?
removing the cervix, ma'am.
Then
Total
you tell what you're doing, no?
yes, ma'am.
When do you want to leave the cervix behind? Now you only asked.
If the patient wants to have if the patient wants to continue sexual.
That means after hysterectomy, no sexual life, huh? After
No,
total
ma'am, no,
hysterectomy.
ma'am, no.
Huh? Usually, when do you do subtotal?
Subtotal hysterectomy.
When do you do?
Young, 32 year around.
When do you do?
The cervix is healthy, ma'am.
Usually you do only in emergencies. Which emergency?
Cesarean
Usually at that time. Otherwise, subtotal usually nowadays we do. Suppose you do subtotal, what advice will you give?
To have a pap smears done.
She has to follow up with pap smears.
Follow up with pap smears.
Yeah. So in your case, you want to leave the cervix behind or what?
No, ma'am, remove the cervix.
You want to remove the cervix. Okay. So now what will you clamp next? You clamp the McIntosh, uterosacral over. Next. You must have done so many, no? Or you must have assisted so many, at least. Yes. Yeah, somebody has already put the answer in the chat box.
Alt closure.
Yeah, so you clamp the angles, isn't it? Won't you do the angles before? Okay. How will you prevent vault prolapse? Even abdominal hysterectomy, they can have vault prolapse, right?
You can advise Kegels exercise.
No. During surgery, what precautions?
Pelvic floor repair.
Sorry?
No, sorry. What?
How will you take precautions to prevent vault prolapse in future? What are the causes for vault prolapse?
Weak asthenia of the muscles, weak muscles.
No, during surgery.
During
what are the causes for vault prolapse later?
If you don't repair what it will happen.
What if you miss? Somebody has put it in the
yes.
box. You can read there.
Yes.
Yes, introsil, isn't it? So
You fail to repair introsil during the hysterectomy.
Is there? How do you repair? What is that called?
Anterior colporrhaphy, ma'am.
No, introsil repair. For the stitch.
Anterior colporrhaphy is what? Any interim is related to anterior vaginal wall.
That's for
And per abdomen, what do you do? Per abdomen, peritoneum, posteriorly, pouch of Douglas, you obliterate. What is that called? First string sutures you take.
First string sutures.
What is that?
Already they have put it there. See, Michael's yeah. Okay, so you have to do that. That is one, and the other one is fixing the uterosacrals to the angle. Okay, so those two can prevent to some extent further wall prolapse later. Okay, yeah. Ma'am, you can ask ma'am, Shubha ma'am and others.
I think we can close now.
Yeah, I think
Oh.
we have only 1 minute left. So any questions?
Students, if any questions you can ask, only 5 more minutes.
Ma'am, just one question.
Ma'am, 1 minute, 1 minute. Dr. Jayanti, I saw
Yes,
the
ma'am.
question. They want to confirm about that inversion and polyp, clinical difference.
Yeah, so polyp, it appears pale. Suppose it is near the os, it appears pale and doesn't bleed on touch. If it's inversion, endometrium is pale pink or reddish pink, and it may bleed on touch. Okay, that's two things. And on pelvic bimanual examination, fundus will not be felt. Okay, no
Regarding you
sound can be introduced. No, definitely don't introduce sound if you're in a doubt whether it's a polyp or inversion. No sounding. Okay, no sounding. Bimanual examination, you cannot feel the fundus in case of inversion. Whereas if it's a fibroid polyp, you can feel the fundus nicely. No sounding at all. If in doubt, don't sound. Any other questions? Any other questions I can answer?
No other questions in the chat box. Almost everything is answered.
Okay.
Yes, Sheila, you have answered very well, but
Yes.
you have to prepare still more.
Yes, yeah. They've answered well. I think both of them have answered well. Yeah.
Yes.
The first year student, she has answered well.
Yeah, she's answered well. Yeah.
On table precaution to reduce blood loss in large fibroid, ma'am.
Yeah, so one is like this, as she said, you can GNRH and do it. Then you can intraoperatively, you first clamp the uterines, both sides. Usually you clamp on one side, then do it on the other side and all that. So you can clamp on both sides and go ahead. And suppose you're leaving the ovaries behind, then of course, ovarian precautions you will take, that's all. Okay. Only if you are doing myomectomy, then you can use other methods. But in hysterectomy, both sides you apply the clamps and then go ahead. Usually what you do is one side you will apply and then later next side. So both sides, if you clamp and then cut in ligate, maybe you can minimize a little blood loss. That's all. Otherwise, using of GNRH to reduce the volume. I think that she answered already. Sheila had answered that.
Remove a posterior wall fibroid in abdominal myomectomy.
Yes.
How to remove a posterior wall myoma in abdominal myomectomy?
Yeah, like of course, earlier we used to say always go from anterior. If you're doing a laparotomy, always the incision should be anterior. That was the instructions given. I think now with the development of laparoscope, they are putting incisions anywhere, everywhere, whichever is easier, they're putting. Suppose it's posterior wall, they go ahead with the posterior wall. If it is anterior, they put it in the anterior wall. But ideally, if you're doing a laparotomy, then maybe you can go through anterior wall and remove. Main reason is that they say suppose additions are little less because posterior it can go stick on to sigmoid or whatever it is. Additions comparatively anterior additions are lesser compared to posterior. And secondly, suppose there's future pregnancy and dehiscence, easy to identify anterior compared to posterior, and repair also is easier when it is anterior. That was the reasons they said you have to have the incisions anterior. But now laparoscopy, I don't think they go from anterior to posterior. They put an incision posterior itself wherever is a fibroid and then remove.
I think that's all. Any more? Kalpana?
Yes, ma'am.
Proceed with 4 tough times.
Yeah.
Any bleeding out to rule out pregnancy complications. That is very important.
Sorry, ma'am.
First episode. Pregnancy, madam. That is a young patient, first episode. Many times they won't tell the history of amenorrhea. So we have to rule out pregnancy and its complications.
Thank you, Shanta ma'am and Jayanti and Dr. Subba.
Thank you, Sampath ma'am, for giving me the opportunity. It was really nice to be associated.
Yes. And
Thank you, madam. Thank you, Sampath madam.
Thank you, Kalpana.
Thank you, ma'am.
Thank you, Sheila and
Shubha.
Thank you, madam.
Thank you, ma'am.
So ask your
Thank you,
friends to
Jayanti,
join
ma'am.
on every Saturday, last Saturday of every month.
Okay.
Some interesting. This is not an exam. Just you can clear all your doubts.
Yeah. Don't feel hesitant. This is a place where you can clear all your doubts. Yeah.
That too from eminent persons, you can clear your doubts.
Nalla panna, Subba.
Thank you, madam. Thank you.
Thank you,
Thank
ma'am.
you. I hope it was useful and thank
Yes,
you.
ma'am.
Very
Very
useful.
useful, ma'am. Thank you, ma'am.
Thank you. Thank you.
Thank you, ma'am.
Thank you.
Thank you. Bye.
Anyway,
Thank you very much.
Thanks to all. Healed people, doctors. Chitrakala is not there. We can close. Thank you.
Okay, ma'am.
Felicia, thank